All right, so as you all know, I'm Emily Jandisek, and I am doing my project on pediatric spinal cord injury guidelines. So today we're going to be talking about pediatric spinal cord injuries. So my objectives are for you to understand the background and epidemiology of pediatric spinal cord injuries, as well as the unique pathophysiology and management principles, and to recognize and manage complications that can occur, and to understand the prognosis and complexity of rehabilitation. So a little bit about the background. The spinal cord is approximately 18 inches long in an adult person. It is divided into 4 sections. You have the cervical vertebrae, which is C1 through C7, thoracic vertebrae, T1 through T12, lumbar vertebrae, L1 through L5, and sacral vertebrae, S1 through S5. The spinal cord functions with motor function, which impacts your ability to control movements, and then sensory, to be able to sense pain, pressure, touch, vibration, and temperature, and then autonomic control, which regulates your temperature, sweat, bowel and bladder control, and sexual function. So there are approximately 17,000 new spinal cord injuries each year. 3 to 5% of these injuries occur in children younger than 15. Children that present with a traumatic brain injury have a 40 to 50% chance of also having a cervical spine injury. At Helen DeVos Children's Hospital, we have an average of 6 spinal cord injuries each year. So low volumes, but very complex. Mortality rates. So on here I have high resource settings and low resource settings. And this is just to show the time of treatment impacts the results that you'll see with mortality and morbidity. It's completely affected by healthcare delivery. So the transportation and time of admission are factors for survival and complication development. There was a study in Australia that they found if it took longer than 24 hours before a patient suffering a spinal cord injury was treated, they were 2.5 times more likely to develop secondary complications in comparison to those admitted and treated upon arrival. So quick recognition, early evaluation and management should improve your mortality and morbidity rates. This graph just shows the distribution of spinal cord injuries among gender through the age groups. Initially it's about equal male-female ratio, 0 to 5 years, and 6 to 12, and then once you get into the adolescent period, males predominantly are affected, 4 to 1. And then this graph shows you the causes of spinal cord injuries. The leading cause in all age groups is motor vehicle crashes, followed by violence and sports, and that's consistent through all age groups. So the American Spinal Cord Injury Association came up with this impairment scale. It's used to define and determine the extent and severity of a patient's spinal cord injury. They're graded according to sensory and motor function, and it's ideally completed within 72 hours. They do sensory testing, so they do like a pinprick and light touch, and then they do motor testing to your key motor muscles for range of motion, contraction, and resistance. And then the severity of the spinal cord injury is rated from A to E. A is the most severe and E is the least. And then that is directly related to the risk of complications. The higher the level of the injury, the greater the risk of complications that they could develop. This is the cost spinal cord injuries have. The higher the level of the injury, they're more related to higher costs in the first year. And then it shows that each subsequent year, it gets a lot less. So tetraplegia is associated with higher cost than a paraplegic. And then after the first year, each year it drops drastically. So this is the Haddon matrix, which is a preventative tactic for the #1 cause of spinal cord injury, which is motor vehicle crash. So you have pre-crash prevention, so this would be like law enforcement and driving regulations. And then you have crash prevention, so restraints, the proper use of car seats for the appropriate age groups. And then you have post-crash, which is determined by us and medical care that we provide to patients to prevent further injury and sustain life. So pathophysiology, there's two mechanisms. There's a primary injury and a secondary injury. A primary injury occurs at the moment of impact, and then it leads to structural damage. So there's four mechanisms. You can have impact with persistent compression, which is like a burst fracture. Those are the most common. And there's impact with possible transient compression. Those are your hyperextension injuries. And then distraction, which is forceful stretching or a shearing injury. And then laceration and transection. And then the secondary injury that can occur within minutes to days after the injury, and it initiates a cascade of events, which we'll talk about. So this is what occurs during the primary injury. The central gray matter is damaged while the white matter is relatively preserved. The damage to the gray matter is thought to be irreversibly damaged within the first hour, and then the white matter is irreversibly damaged within 72 hours. So you have apoptosis and necrosis. You have demyelination of the axon, which will affect your synaptic transmission. You'll have macrophages and astrocytes that form a glial scar, and you'll have damage to the axon. Hemorrhage, edema, and excitotoxicity also occur. So this is the secondary injury, which follows the primary. Patients can present into neurogenic shock. This is manifested by bradycardia, hypotension, and a decreased cardiac output. It results from an inadequate tissue perfusion, which creates disturbances between the balance of vasoconstriction and vasodilation. And this is different than spinal shock, which I have a different slide to differentiate between the two. They have vascular disruption, which causes hypoperfusion and ischemia. This occurs at the site of injury, and can cause vasospasm of your vessels, and edema can follow. You also have free radical production. So the vascular disruption leads to a decrease in the amount of available oxygen, and lactic acid builds up, as well as free radicals. This in turn can lead to apoptosis and necrosis. And then you have glutamate, which is released during this time of injury, which is a excitatory neurotransmitter. When this is released, it causes sodium and calcium to flood into the cell, which can cause swelling, lysis, and cell death. You also have an inflammatory response, so neutrophils, macrophages, prostaglandins, T cells, all flood to the site of injury and can cause vascular permeability changes, endothelial damage, and edema that can result in scarring and irreversible damage. These are the risk factors for young children and cervical spine injuries. So the spine does not assume adult characteristics until about age 8 to 10. Children younger than 8 are most susceptible, therefore, to cervical spine injuries. They have a disproportionately large head with weak neck muscles, and then the point at which their head pivots is positioned higher than an adult, which places them more at risk. They have ligamentous and joint capsule laxity, and then they have horizontal facets that allow for increased movement with flexion and extension. And then they have an increased cartilage to bone ratio. So these are the secondary complications that are associated with a spinal cord injury. It's determined by the level of injury. 1/2 of all these secondary complications occur within the first week of hospitalization, while 3/4 occur within the second week of hospitalization. These can all prolong hospitalization, impair neurological recovery, and increase medical costs. And then pulmonary complications are the most common cause of mortality among the pediatric population. So my project includes implementing clinical guidelines. Clinical guidelines are statements that are a systematic review of evidence, and they're aimed at improving patient outcomes and optimizing healthcare delivery to improve the care we deliver. Some examples: there was clinical guidelines implemented in a surgical setting and they saw a decrease in postoperative infection rates. And then a spinal cord injury unit also implemented spinal cord injury guidelines, and they saw a 50% reduction in hospital length of stay and a reduction in mortality and an increase in neurological recovery.
Can I interrupt with that?
Yeah.
What was the p-value with the significance?
Less, it was less 0.001.
Pretty good.
Mhm. So the purpose of my guidelines will be to identify infants and children at risk and adolescents with a known or suspected spinal cord injury. We aim to reduce the morbidity and mortality associated with the direct care delivered, and then prevent secondary complications, which can decrease length of stay and ongoing costs of care. So the goal of management is to prevent further injury and minimize secondary injury. The initial management will include immobilization. This should be occurring in the emergency department, and that is the application of a cervical collar. They will remove a backboard and stabilize the spine, often with a halo or a brace. And patients should be log rolled while they're on the unit, as well as if head of the bed elevation is desired, they should have reverse Trendelenburg until cleared. And then early surgical reduction and decompression might occur. This typically is within 24 hours to stabilize the spine and reconstitute the spinal canal. Hemodynamic support is often needed to maintain a spinal cord blood flow and perfusion. According to the Congress of Neurological Surgeons, we should be maintaining a mean arterial pressure between 85 and 90 for 7 days following injury. So this can be achieved with fluid resuscitation. And then on the back of the cards that I gave you is vasopressors. An ideal agent would be an alpha and beta adrenergic agonist to offset the loss of sympathetic tone and give chronotropic support to the heart. So dopamine is our first line agent.
And how many that blood pressure is it pediatrics too?
And the epinephrine is 0.05 or 0.5?
Should be 0.05. Yeah.
Norepi is 0.05. I thought epinephrine was the hard units.
No, 0.05. Yeah. A high dose would be 0.1 for epi, which is like a code dose if you were to give it.
Yeah.
Respiratory support, so higher level of injuries result in more respiratory complications. However, lower level injuries also, you will see atelectasis and pneumonia at a rate of 60%. And then just knowing that the higher level injuries might need ventilatory support. A quadriplegic patient has a vital capacity and a tidal volume that is greater in the supine position because the abdominal contents help with ventilation. And then knowing that patients suffering a spinal cord injury are at risk for sleep apnea. Automatic respiration is regulated by the cervical spine. And so if that is damaged, they might be able to breathe fine while awake, but when they are sleeping, breathing could stop. So a pulse oximeter should be used for 7 to 10 days after injury.
That's at any level?
Mm-hmm. Oh, cervical spine. Temperature control is regulated by the autonomic nervous system. So if that is impaired, you can have issues with thermoregulation, and the goal is to maintain normothermia. There is research out there about hypothermia, but right now it's recommended to maintain normothermia. So the two types of shock, you have neurogenic shock and you have spinal shock. Neurogenic shock is a loss of vascular tone from inadequate circulating fluid and third spacing. They can be hypotensive, bradycardic from the interruption of the sympathetic nervous system. It's more commonly associated with levels above T6, injuries above T6, but they typically respond to fluid and vasopressors. And then spinal shock is your temporary loss of spinal reflex activity. This can occur in days to weeks. Initially, a patient will have areflexia and flaccidity, and then it transitions to hypertonia, hyperreflexia, and spasticity. So spasticity is often an issue with these patients. It's a resistance to passive range of motion that increases with stretch reflexes. They can have exaggerated tendon jerks, and it's typically the period, like I just said, following spinal shock. So therapy plays a huge role in this. We'll talk a little bit about therapy later, but range of motion exercises is really good for this population, and splinting and passive range of motion with stretching. And then outpatient, they will often have functional electrical stimulation and hydrotherapy. And then you can also start medications, baclofen, Valium, and clonidine are all good for spasticity. So the issue of autonomic dysreflexia. This is typically in patients with a level of injury above T6. It is an exaggerated autonomic response to a noxious stimuli, typically below the level of injury. So you have a noxious stimuli such as a distended bladder that sends a signal up, causing hypertension, and the brain signals that, and then it sends a signal down the spinal cord, passing the vagus nerve, causing bradycardia. So you'll see hypertension, which can be like 20 to 40 above baseline, bradycardia, flushing, intense sweating, and nasal congestion, anxiety. So causes, you want to figure out if there's a noxious stimuli causing this. It could be a full bladder or bowel, tight clothing, fractures, pain, pressure ulcers. And then you want to remove the noxious stimuli if you can, so whether that would be doing an intermittent catheterization or bowel disimpaction, pain medication you can give, but temporarily you can elevate the head of the bed, and then there's antihypertensive agents you can give, nifedipine and hydralazine is what has been recommended by our pharmacy and through research as well that I've read. So the GI system, to prevent gastric atony and paralytic ileus, these kids can have a nasogastric tube in place to low intermittent suction. This will prevent aspiration and vomiting, and hopefully help with your respiratory function. We want to minimize the abdominal distension, prevent ulceration with Zantac, to maintain a gastric pH above 4, which can also assist in preventing ventilator-associated pneumonia and decrease the risk of a GI bleed. Bowel regimen should be started on these patients. These are different classes of medications that can be used in this population, as well as suppositories if needed. A spinal cord injury, they typically lose colonic motility and sacral reflexes, and 80% of children will require an oral, rectal, or combination medication regimen to facilitate a bowel movement. Nutrition is recommended to be started early. It should be started within 72 hours if feasible. Post-traumatic injury, even with like a traumatic brain injury, they are in a hypermetabolic state. This depletes their energy stores. They lose lean muscle mass. It reduces protein synthesis. They lose gut integrity and immune compromised. And then even more specific, a spinal cord injury has a lower resting energy expenditure than a traumatic brain injury. They also have lean body mass loss due to denervated muscle. So this results in atrophy, and then they have a large nitrogen loss. So starting early can prevent this nitrogen wasting process or help with it. And then GU, during spinal shock, their bladder can be atonic and flaccid. So initially inserting an Adolin Foley catheter can help with this. And then like we've rolled out our cautery prevention, removing it as soon as feasible, and switching to an intermittent bladder catheterization. This can be done every 6 hours. We've talked with urology, and they've recommended not bladder scanning. Every 6 hours should be adequate, unless they're experiencing signs of autonomic dysreflexia, and then you can straight cath sooner. And then doing a consult for them as well, so they can obtain like a baseline cystogram and renal ultrasound, and then possibly starting medication to help with the bladder musculature. So deep venous thrombosis, it's not very common in pediatrics. It occurs in less than 15% of patients, but it can be fatal. It can lead to a pulmonary embolus. So these patients should have prevention started, including the intermittent compression stockings, early mobilization if able, or a low molecular weight heparin or unfractionated heparin. And there's a protocol, I believe, coming out too that we will start to follow and reference in the guidelines. So these patients are at risk for pressure ulcers. They get a loss of sensation to pain, pressure, and touch, as well as temperature. So this causes them to be at high risk for breakdown, and we should be monitoring this. We're going to be having nursing do full head to toe skin checks every 8 hours, and then assessing under the cervical collar at least every shift, and looking at those pressure points. And then just to keep in mind, if you know the patient's going to be here a while, according to their level of injury, ordering a specialty mattress might be indicated and good to help protect their skin. So one big controversy, and there's a lot of research out there, was the use of steroids. Currently, the Congress of Neurological Surgeons does not recommend steroid administration. There have been 3 Class 1 studies that have shown an increase in wound infection rates, GI bleeds, hyperglycemia that requires insulin therapy, higher rates of mortality, and it has not shown any to improve neurological recovery or functional recovery. And then there are multiple Class 2 and Class 3 studies with the same evidence. There's even less evidence in the pediatric population. There was one study in 2015 that looked at the administration of high-dose corticosteroids for spinal cord injuries. There was only a sample of 35 patients, and they did not see a difference in infection rates. There was 1 GI bleed with the steroid group, and hyperglycemia was noted in both the steroid and non-steroid group. So there's definitely more research that needs to be done, but right now it is not recommended. So recovery. This diagram just shows you a full potential of neurological and functional recovery. And then you have the purple circle, which is their neurological recovery after the spinal cord injury. And then you have your functional recovery, which is completely limited by your neurological recovery. So depending on the extent of injury, it's going to be directly related to how much function they're going to retain afterward. So rehabilitation is a big thing with this population. We should be ordering PT and OT within 24 hours of admission to help facilitate neurological and functional recovery, and then ensuring that it's actually being completed weekly and they're getting the range of motion, or teaching family or nurses as well to do passive range of motion or splinting, as well as active range of motion if able. So outcomes, it's completely limited by the level and severity of injury for the functional and neurological recovery. It's also dependent on age. As your age increases, the risk of mortality and recovery is worsened. And then males typically have a higher mortality rate, but again, it affects males more. And then if they have 1 or more comorbidities, if they have a TBI as well, or if they have a severe systemic injury, it increases their chance, or it decreases their chance of survival. So future research, I kind of talked about the neuroprotective agents with the steroid use. They need to look at that more, as well as in the pediatric population. There are also neuroregenerative agents. So like gangliosides, they have been shown to regenerate the axon and repair the neuron. And then there are cell-based therapies. Schwann cells migrate to the spinal cord. And so if we transplant Schwann cells, it could facilitate invasion to the host, of the host Schwann cells to the injured spinal cord for repair. And that's still being studied, as well as like stem cell transplant.
Narcan written up there.
Yeah, and then there was a couple of other ones which I didn't read and touch on too much in my research. Steroids were the big one, but there are some studies with that. And that is it. These are my references.
I have a quick question.
Yeah.
So when you talk about autonomic dysreflexia,
Yeah.
like in a traumatic brain injury patient, we sometimes will start them on propranolol
Yeah, for
to help with that.
dysautonomia. Yep.
Do you see that with these spinal cord injury patients, or is it more that it's just like this intermittent due to a noxious stimuli, so
Right.
that doesn't help?
Right.
Or so you don't
No,
usually
not
use...
unless there's like a concomitant TBI
Okay.
with it.
Okay.
Yeah.
So it's more just get rid of the noxious stimuli, figure out what that
Correct.
is, and then...
A hypertensive agent if you have to.
Yeah. Okay.
Yep.
Okay.
There was a slide on assessing the sensory involvement.
Mm-hmm.
What was there like a recommendation
So it's within, yeah, I might have to go over here. So that should be done within 72 hours. And I think we determined orthospine would do that. Right here. And then they would give you a grade, an A, B, C, D, or an E.
Okay. That's really interesting.
There's actually the association that's listed on here. They have a really good site that will go through neuro exams and spinal cord injuries in really good detail, and it'll show you exactly how to do this. There's like a video on it, which is really good.
Is there a guideline coming out, you said?
Guideline, yes, yep. November is the set date.